One of the major challenges facing the emergency medicine today is the increase in not only patient volume and acuity, but also the decrease in available well-trained providers. Mid-level providers have been an invaluable asset in terms of meeting the demand or the need to be able to take care of patients in the emergency department. Our own experience within Epic demonstrates this quite well over the last 6 years. Of our provider base, nearly 40% now are physician assistants and nurse practitioners who are specializing in emergency medicine. Currently, within Epic and also within the PIAA community, the Physician Insured Association of America, we are seeing a rise in the amount of malpractice claims associated with using mid-level providers in the emergency department. And that's a two-way street. And one of the reasons is that they're seeing more patients, so it stands to reason that, in fact, they have greater exposure. But the other areas that seem to fall out are areas in which there's communication problems or handoff problems between the physician and the mid-level provider. Common areas of malpractice litigation involving mid-level providers include failure to appropriately supervise them, failure for communication, as I've already mentioned, and practicing beyond their scope of training.
In regards to using mid-level providers in the ED, the Epic Risk Management and Patient Safety Committee, which is a group of practicing physicians, our physician insureds, actually spent extensive research and time looking at the use of mid-level providers. They did surveys, they developed a document with the help of risk management experts to really frame the use of mid-level providers. This document includes job descriptions, orientation process, competency evaluation, quality review, as well as peer review for the mid-level provider. In general, the mid-level provider guidelines are suggestions, but in there are tips. Some of the tips include really knowing your state law, any regulatory issues that might be specific to the state. Also confirming appropriate training and experience. Mid-level providers may be trained specific to ED or they may not. Really looking at the formal designation by the governing body, whether or not the mid-level provider is going to be able to be a qualified individual who can perform a medical screening exam under EMTALA. Also looking at formalizing what type of patient conditions can the mid-level provider see. One of the areas where often there's some restriction as far as independent practice might be the patient with an acute condition such as chest pain or a PEDS fever under 2 months, or having the mid-level provider really working as part of the team. Mid-level provider guidelines also outline the information in regards to the supervising physician. Who's actually supervising the mid-level provider for each patient encounter?
There's no real common or standard model with regard to the delegation of scope of services for mid-level providers in the emergency department. Some of the more common ones that we do see, first we might see a practice scenario where mid-level providers see all different levels of acuity of the patient independently. They usually have guidelines for which patients they need to present to the physician supervisor. A second model, which we see quite frequently, is where the mid-level provider works as a team member in conjunction. So all patients are essentially seen by both the physician and the mid-level provider. The third one, which is also quite frequently used, is the designation of a mid-level provider to a certain level of acuity. Sometimes that's in urgent care or a fast track, but it may be a wound clinic, it may be pediatrics. It's really about marrying the training and expertise of the mid-level provider to balance out the workload of the patients that are being seen in the emergency department.